So let's start with Mustafa.
Okay, hello everyone. One more time, I would like to welcome you all Dandy members for this fifth meeting for Dandy Iraq. And indeed, this would be the second presentation in the neuroanatomy course, the basic neuroanatomy course. We are launching this few months. And today's presentation topic will be about the functional areas of the cerebral cortex. Let me introduce myself. I am Mustafa Murayati, a fifth-year medical student at Baghdad College of Medicine. I'm a scientific officer at Dandi, Iraq. The contents of this presentation will be talking about the functional areas of the cerebral cortex, and we will focus on the Brodmann areas. What are the functions of each most important area, and what the lesion happens, what are the consequences. And then we will talk few seconds about the cerebral dominance at the end of this presentation. So an introduction about this topic, the Brodmann areas, as we can see here in this figure of the brain surface, there are 47 Brodmann areas. The neurologist who discovered it, Corbinian Brodmann, he's a German neurologist, he describes a 47 Brodmann area in the cerebral cortex, and indeed he depends on the cell type and the thickness of the cerebral cortex in deciding enumerating them. And we will take each lobe by its own and talk about the functional areas of them. Starting from the frontal lobe, then we will talk about the parietal lobe, then temporal lobe, after that the occipital, and finally the insula. Let's recap the brain lobes surface anatomy we took in the last presentation. And here's the lateral surface of the cerebral cortex. And here are the brain lobes. The yellow one is the frontal lobe, the orange one is the parietal, the occipital in blue, and the temporal in the green. Here are the main four brain lobes. We'll start from the frontal lobe. Let's take the quick recap about it. Here we have the superior frontal sulcus. Here is the inferior frontal sulcus. And here is the superior frontal gyrus, middle frontal gyrus, and the inferior frontal gyrus. And here is the precentral gyrus, and that's supposed to be the central sulcus. Here we have the Sylvian fissure. This is the ascending ramus, and this is the anterior horizontal ramus. And we mentioned also that the inferior frontal gyrus has three subdivisions, the parts of opercularis, triangularis, and orbitalis. Okay, that was from the lateral surface. Let's have a look at the medial surface. The yellow area represents the medial frontal surface or the superior frontal gyrus from the medial view. And here we have the corpus callosum, and the sulcus around the corpus callosum is the callosal sulcus. And then we have, this is the cingulate gyrus, and this is the cingulate sulcus with the marginal sulcus over here. And indeed, we mentioned that this area over here is termed as the paracentral lobule. It's critically important in our presentation for today to have an idea about it anatomically. Indeed, this is the cingulate sulcus, and this is, we mentioned the ascending ramus, the marginal sulcus of it, and the other sulcus that's originated from the cingulate sulcus is the paracentral sulcus over here. And the most anterior sulcus in front of the marginal sulcus is the central sulcus. So what's in front of it is the precentral sulcus. That is just recap for the surface anatomy. Now let's start with the functional areas of the frontal lobe. Indeed, we have these 6 areas we will talk about: the primary motor area, the premotor area, or what's called the secondary motor area, the supplementary motor area, frontal eye field, Broca's area, and the prefrontal cortex. Okay, let's start with the primary motor area. It is designated as Brodmann area number 4. So it's located in the precentral gyrus. This is the red area over here on the lateral surface of the brain, and here is on the medial surface of the brain. This is the central sulcus. What's in front of the central sulcus is the precentral gyrus. So this is located in the precentral area. Indeed, the precentral area in front of the central sulcus is divided into two parts, the posterior part and the anterior part. The posterior part is the primary motor area, and the anterior part, which is slightly more anterior to Brodmann area number 4, which also takes part from the superior, middle, and inferior frontal gyri. We will talk about it in the next few slides. Okay, so now we're starting from the primary motor area. This is from the lateral surface. It's has a demarcation anteriorly by the precentral sulcus. So this is the precentral sulcus. And let's have a look about it from the medial surface. Here's the medial surface. This is the cingulate sulcus, and this is the marginal sulcus. And we mentioned what in the front of the cingulate of the marginal sulcus is the central sulcus. So here's the central sulcus. In the front of it is the precentral gyrus, which is our motor gyrus we are talking about now. And what's behind it, we will talk about it later on. Okay, the precentral gyrus, it's also called the motor strip because it's the main motor cortex, and it has a body representation inverted, starting from the tongue, face, neck, thumb areas, then the hand, and then the arms and the supromedial surface. And then we have the trunk, the pelvis, the legs, and the foot on the medial surface. We will have a more detailed idea in this slide about what was that representation looks like. This is called the motor homunculus. Homunculus is a Latin word, means a little man. So this little man has some big parts and some small parts. Indeed, the big parts represent the skilled areas that require fine motor skills. So the representation in the cortex will be much bigger than other parts. For example, the hand, the thumb, the tongue for the speech, the face are an important part for some skilled movement. And here is the representation on the cerebral cortex. Let's imagine this is a coronal section, and this is the lateral surface, and here is the medial surface. So it started from inferiorly. Here's the laryngeal and pharyngeal structures. Here we have the mouth area with the tongue and the face area, and then we have the hand area. Especially there's a big representation for the thumb and index finger. And then we have the upper limb, shoulder, the trunk, and the pelvis. And here we are reaching this supromedial surface. It transitions from the trunk and pelvis to the lower limb and the genital tract, the genital, I mean the anal sphincter or the vesical sphincter, also controlled on the medial surface of the cerebral cortex. Now let's talk about the functions and lesions that happen to this Brodmann area number 4. Well, we talked about how it's a motor strip. It's a major motor fibers descending from this area to the spinal cord or to the brainstem, to the head and neck structures. If there is a lesion in the, for example, the right Brodmann area number 4 or precentral gyrus, we have contralateral spastic paresis, which is called upper motor neuron lesion on the left side. If it's the lesion on the right, then the defect on the contralateral side on the left side. And there is a little note here that tell us that there is bilateral movement of the extraocular muscles, upper face, tongue, mandible, larynx, and pharynx. So it's not a unilateral contralateral movement for these structures only. It is bilateral. Now, after finishing the primary motor area, let's talk about the premotor area, or what's called the secondary motor area. It's represent the Brodmann area number 6, which is just anterior to the primary motor area in the red. It represents the area precentral gyrus and anterior to the primary motor area. It is wider superiorly than inferiorly. It takes some part, the posterior part of the superior, middle, and inferior frontal gyrus, which is over here. This is on the medial surface. It has a slight representation over here. Well, there is some debates you may hear as I'm speaking and presenting this presentation. Some Brodmann areas have conflict about their representation. For example, the premotor area, some of which tell us that it's just number 8, and some tell us that's 8, 44, and 45. So it depends on the references you're reading. Okay, so what's the function to the Brodmann area number. For example, we are talking about 6 and 8, the premotor area. Well, let's imagine this premotor area as a memory for the motor skills we have. For example, if I want to hold a cup of tea and a drink of it, well, I have the ability to move my arm and hold the cup of tea, and then it's bring it near to my mouth and then a drink of it. But the program of this, indeed, particular movement is stored in the premotor area. Okay, if the lesion occurred here in the premotor area, I will lose this ability, and this is called apraxia. Apraxia means inability to perform a movement without a motor deficit. And for example, if you tell a patient who have a lesion over here to move their hands, they can move it. But if you tell them, would you tie your shoelace, they cannot perform that specific task. So it is just that store programs of motor activity. Now we will talk about the supplementary motor area, the SMA region. It's mainly represented on the medial surface, just anterior to the paracentral lobule. So here's the paracentral lobule. Just anterior to it is the supplementary motor area. Well, its function is not well understood or known. It is postulated may have postural stabilization of the body, this function, and there is no big significance if a lesion occurred here. So just to mention, there's a supplementary motor area and their presentation is over here. This one also. Now, one of the important functional areas in the frontal lobe is the frontal eye field, or the FEF. To present Brodmann area number 8, as I mentioned, maybe some references tell us 6, 8, and 9 Brodmann areas. So it's located in the middle frontal gyrus. This is the middle frontal gyrus, just anterior to the area represented of the face in the precentral gyrus. So can we imagine this is the central sulcus, this is the precentral gyrus, this is the postcentral gyrus. And we mentioned that the body representation, the motor homunculus we showed earlier, it has the pharynx, larynx, the face over here. So in front of the face representation is the frontal eye field, is located in the middle frontal gyrus. Well, its function as a center for contralateral horizontal gaze. For example, if I want to look on the right side voluntarily by my own will, I will work my left frontal eye field to make a conjugate horizontal gaze to the right side. So it's a contralateral horizontal gaze. If lesion occurs, for example, on the right side, the eye cannot go to the left side. So it comes to the ipsilateral side of the lesion. So eyes deviate to the ipsilateral side. For example, here, this man looks to the right side. The lesion should be on the right side in the frontal eye field. Okay. One of the most important cortical areas also, the Broca's area, which is the motor speech area, area 44 and 45. It is represented here in the inferior frontal gyrus. Actually, it's part of the pars orbitalis and pars triangularis, but not the pars orbitalis. Okay, it is just superior to the margin of the sylvian fissure. In the dominant hemisphere, it is the motor speech area. Actually, we classify the hemisphere as dominant or non-dominant based on the speech area. If it's in the left hemisphere, so the dominant hemisphere is the left, or if it's in the right, then the dominant hemisphere is in the right. Lesion in the Broca's area, Brodmann area 44 and 45, will produce Broca's aphasia, or it's called also expressive aphasia or non-fluent aphasia. Indeed, if you have a close look at this area, it is close to the area represented in the motor cortex for the pharynx, the larynx, the lips, the tongue, the face area, which all responsible for production of speech. So since it's in close proximity to these areas, we can imagine there's a problem in speech production. So the patient can understand what is he being told, but he cannot respond. So they are aware of their problem. as we will talk later about the Wernicke's aphasia, which is really different from that scenario.
Hi, Mustafa.
نعم عمي.
Okay.
Okay. This is also called the non-fluent aphasia because the patient may say like small cutted syllables. They do not speak fluently, as we will see with the Wernicke's aphasia. They speak fluently, but the nonsense speech, indeed. Okay, now we will talk about the prefrontal cortex, the Brodmann area 9, 10, 11, and 12. It represents the majority of the frontal cortex. About a quarter of the cerebral cortex is represented by the prefrontal cortex. On the lateral surface, this is the demarcation, superior, middle, and inferior frontal gyri. The orbital gyrus is also involved. And on the medial surface, here we have the medial frontal gyrus, most of it, and the anterior half of the cingulate gyrus. So this is the area represented by the prefrontal cortex. Indeed, the function of the prefrontal cortex is the personality. We should have a generalization ideas about the lobes, as we are talking about the frontal lobe. So you should have in mind at least two important things as you hear of the frontal lobe. The first is the personality. The personality is located in the frontal lobe. And the second is the motor cortex. So the motor cortex also located in the frontal lobe. Okay. Lesion in the prefrontal cortex will produce the frontal lobe syndrome. It's difficulty concentrating and problem solving, easily distracted patient, inappropriate social behaviors, apathy, and poor judgment. These are all signs of frontal lobe syndrome. So let's recap. I know we talked a lot of information in the past few minutes about the frontal cortex, but I promise it was the hardest part of this presentation. Okay, the first gyrus in front of the central sulcus is the prefrontal, the precentral gyrus, which is the motor strip. In front of it, the premotor area. In front of it, the supplementary, and then we have the frontal eye field. Here is the Broca's area, and this is the frontal prefrontal cortex in the green. Now let's move on to the parietal lobe. We'll take a quick overview about the surface anatomy. This is the parietal lobe. It's located between the central sulcus anteriorly and the parieto-occipital sulcus posteriorly, and inferiorly it has the Sylvian fissure and continuation with the temporal lobe. Here we have the interparietal sulcus. Will divide the parietal lobe into superior parietal lobule and inferior parietal lobule. And in the inferior parietal lobule, indeed, we had two regions, the supramarginal gyrus and the angular gyrus. Okay. Here, the purple area represents the postcentral gyrus, which is located posterior to the central sulcus. It's the first functional area we will talk about. And then on the medial surface, here we have, this is the paracentral lobule. As I mentioned earlier in the beginning of this presentation, this is the cingulate gyrus and this is the cingulate sulcus. This is the marginal sulcus. In the front of the marginal sulcus is the central sulcus. So this is the frontal lobe anterior to the central sulcus. And what is behind it, it's regarded as the parietal lobe. So this is the postcentral gyrus, medial representation. And this is also a part of the parietal lobe on the medial surface. It is the precuneus. In the parietal lobe, we will talk about three main functional areas: the primary somatostatic area, the secondary somatostatic area, and the somatostatic association cortex. Let's start with the first part, the primary somatostatic area, Brodmann area 3, 1, and 2. Indeed, they are not 3, 2, 1, nor 1, 2, 3. They are 3, 1, 2, according to the direction from anterior to posterior. So they are just like that, 3, 1, 2. This is the sensory cortex. Just as we have the motor cortex, the precentral gyrus, the postcentral gyrus is the primary somatostatic cortex. It lies behind the central sulcus, and has 3 Brodmann areas. We mentioned that. There are a little more details about what is the difference between Brodmann area 3 and 1 and 2, but it's out of spectrum of this presentation right now. Okay, let's remind ourselves one more time about the sensory representation, the homunculus, the motor and the sensory one, and compare between them. On the left, we have the sensory homunculus. Just as for the motor homunculus, we took in the frontal lobe, starts by the pharynx, larynx, tongue, and the mouth area, the lips, the face, the hands, mainly the thumb, the index finger, and then we have the upper limb, the head, the trunk, and then the pelvis, the genitalia, and the lower limbs on the medial surface. Okay, there are a few exceptions about the sensory, let's say, representation on the cortex. Since we know that the sensory representation as well as the motor representation is contralateral to the side of the body. For example, the right hand is represented on the left hemisphere and vice versa. The oral region is represented unilaterally, I mean ipsilaterally, while the pharynx, larynx, and the perineal region are represented bilaterally on the cortex. So any lesion occur in the postcentral gyrus, or what's called the primary somatosensory cortex, Brodmann area 3, 1, and 2, we will have a contralateral sensory disturbances. And we have the exception about the oral, pharynx, larynx, and the perineal region, which are partially affected because they are bilaterally represented. In the second area, we will talk about the secondary somatostatic area, the S2. As we took the primary somatostatic area, it was S1. So S2, it is a small area that's located in the upper lip of the sylvian fissure on the opercula. And it's just a small area with no well understood function or important lesions to be discussed. And now finally, in this lobe, we will talk about the somatostatic association cortex, Brodmann area 5 and 7, which are indeed the superior parietal lobule, representation of the superior parietal lobule from the lateral surface. On the medial surface are represented here in the precuneus portion. It is really has an important function in the sensory. It receive and integrate different sensory modalities, just as for the premotor area, which store the programs for motor functions. Here we have in the secondary somatostatic area, it also stores past experiences about the feelings of touch, multiple sensory modalities, proprioception, size, shape, temperature, whatever different sensory modalities, and integrate them to give us idea. So one can, for example, close eyes and being gave something in hand, he can recognize it by using the secondary somatostatic area. If lesion occurred there, it can cause agnosia. So that's inability or difficulty in recognizing things without seeing them, without using the visual cortex. Now we will talk about a few single lesions in the parietal lobe. The lesions to the superior parietal lobule cause contralateral asterognosis or apraxia. So these are few lesions we will talk about now, just to run quickly about them and no big details. If lesions occur in the inferior parietal lobule, and specifically about the angular gyrus, which represent the area 39, in the dominant hemisphere, for example, the left side, it can cause the Gerstmann syndrome, while in the non-dominant hemisphere, it can cause the neglect syndrome. And we will talk about them now. The Gerstmann syndrome, the patient may have right-left confusion. So he confuses the right side and the left side. He has alexia, difficulty reading, dyscalculia or acalculia, difficulty in counting, and dysgraphia, difficulty in writing or inability to write. Finger agnosia, he cannot identify his fingers like index, thumb, middle finger. He has difficulty with that. And contralateral hemianopia or lower quadrant synopia. So these are some of the signs of the Gertzmann syndrome. While in the non-dominant hemisphere, we may have the unilateral neglect syndrome, in which, for example, the non-dominant hemisphere is the right one. So he will neglect, or she will neglect, the left side of the body. For example, if they are shaving, they will shave only one side of the body. If they are asked to draw a clock, they will draw only the right half. Okay. They will neglect the contralateral side. Okay, one more area, the gustatory area, for a taste area, area 43, sorry. Okay, it is in the superior margin of the sylvian fissure, just posterior to the area represented by the tongue in the somatosensory cortex. Over here, this is the central sulcus, this is the post-central gyrus, and this is the area represented by the pharynx, larynx, tongue, and lips. So just posterior to it lies the taste area. And here we have the vestibular area, which controls the balance and the posture of the head and the body. It just lies opposite to the auditory area in the temporal lobe and the superior temporal gyrus. So we'll talk about the auditory area over here, and this is the vestibular area over here in the parietal lobe. Okay, so now we will move on to another lobe, the temporal lobe. Let's take a quick overview about the surface anatomy of the temporal lobe. It's represented in the green color over here. This is the lateral surface. And here we have the superior temporal sulcus and the inferior temporal sulcus, which divide the temporal lobe into superior, middle, and inferior temporal gyri. And here, the most anterior part represents the temporal pole. On the medial surface, here we have two main sulci and 3 gyri. Okay, this part is actually part of the occipital lobe, the lingual gyrus or the lingula, and here is the parahippocampal gyrus. But the parahippocampal gyrus and the lingula will form a structure which is called the medial occipitotemporal gyrus. Okay, just lateral to it, we have the fusiform gyrus, or its other name, the lateral occipitotemporal gyrus. And then in the yellow, that's most lateral, we have the inferior temporal gyrus. Well, about the sulci, here is the collateral sulcus, and here is the occipitotemporal sulcus. Here is the uncus, located most medially from the parahippocampal gyrus. It has the hippocampal formation inside it. And here is the anterior temporal pole. That's about the surface anatomy from the medial surface, about the temporal lobe. And here is the rhinal sulcus, just posterior to the uncus. I mean, just lateral to the uncus, behind it. About the functional areas.
Just a reminder, you have about 8 minutes left. So.
Okay, I'll try my best. Okay, now we'll talk about the temporal lobe. Temporal lobe functional areas. We have the primary auditory area, the secondary auditory area, sensory speech area, and we'll talk about the angular gyrus in the dominant hemisphere. Okay, the primary auditory area, which represents Brodmann area 41 and 42, represented over here on the superior temporal gyrus. Actually, it is inside the sylvian fissure. If we open the sylvian fissure by retracted the operculum superiorly and inferiorly, we will see the hishal gyrus or the hishal convolutions. This represents the area for primary auditory cortex. If there's bilateral damage, we will have deafness. If there's unilateral damage, there will be a partial deafness, but to a greater extent on the contralateral ear. Regarding the secondary auditory area, Brodmann area 22, It's auditory association cortex. It lies just posterior to the primary auditory area and the superior temporal gyrus. So it was here, and now the secondary auditory area over here, just posterior to it. It has a function just like for the secondary or the associated sensory or motor area. It has a past experience, memory about the auditory stimuli. So it's necessary for interpretation of sound. If you're calling somebody, you're not seeing them, but you can identify them from their voice. Any lesion over there will cause auditory agnosia. Now we will talk about the Wernicke's area, area 22. It is located. Part of it is the supramarginal gyrus and part of it is the angular gyrus. Well, it's actually located at the posterior part of the superior temporal gyrus with some extension into the parietal lobe. Okay, any lesion in the dominant hemisphere to that area will cause Wernicke's aphasia or receptive aphasia or fluent aphasia. Receptive aphasia because it's a sensory part. As we know, the parietal lobe is a sensory function, has sensory function. So the Wernicke's area, since it's located in proximity to that lobe, it has a sensory function. So it's important in understanding the speech and make a sense of it. And then producing speech will be fluent because the Broca's area is responsible for that function. Just a quick overview about the types of aphasia or dysphasia we have. We may have motor, non-fluent or Broca's aphasia, sensory aphasia. We have global aphasia, which is mixed motor and sensory, conductive aphasia, in which there is a lesion in the arcuate fasciculus, which is a structure or a bundle of fibers that connect the Wernicke's area with the Broca's area. And the lesion over there will cause a conductive aphasia, in which the patient may present with difficulty in repetition of words. They can understand it, but they cannot repeat it, but they can tell it independently. May have nominal aphasia and many other types, which is indeed actually out of spectrum of this lecture. In the hippocampus, its main function in the memory, so may hit the memory. In the amygdala, we have the Colliver-Bucy syndrome, hyperphagia, hypersexuality, and visual agnosia. In the olfactory bulb tract or the primary cortex for the olfaction, we have ipsilateral anosmia, if we have lesion there. Last one, we'll talk about the Mears loop, which is part of the visual radiation. Mears loop, if it's had lesion, we may have contralateral upper quadrant tanopia. Okay, I will not talk about the details of these lesions and the mechanism, but just to mention that. And then now we will talk about the occipital lobe, and after that we will talk about the insula in a few minutes. I should be done with this presentation. Okay, Sama? Okay, so the occipital lobe is represented in the blue area.
Actually, try to, okay, finish your slides as you want, but with a rapid pace, because I think it need by 4 now to listen. Yeah.
Okay.
Do you understand the idea?
Yes, okay.
Yeah, you have 5 minutes more, please.
Okay.
Because we are spending more time with the anatomy rather than the functional.
Okay.
Thank you.
The occipital lobe, we'll start reviewing the anatomy, surface anatomy. We have the lateral occipital sulcus, divide the occipital lobe into superior and inferior occipital gyri, and we have the medial occipital or middle occipital gyrus over here. And the medial surface is really important for us in the functional areas in the occipital lobe, as we have the 2 main sulci that divide the parietal from the occipital lobe, the parieto-occipital sulcus, and the calcarine sulcus, which is coming here and making the Y shape with the parieto-occipital sulcus. Okay, this is the cuneus area, and this is the lingual gyrus. In the occipital lobe, we have three main functional areas: the primary visual area, the secondary visual area, and the occipital eye field. The primary visual area, which is area 17, it lies on both sides of the calcarine sulcus. So this is the calcarine sulcus. On the upper and lower parts of it, we have the primary visual field. Any lesion over there occurred, we may have cortical blindness in the contralateral side of vision. For example, if a patient has left occipital cortex lesion, he may end up with the right homonymous hemianopia. So right visual field is defective on both eyes. Now, the secondary visual area, area 18 and 19, which lies above and below the primary cortical visual area. And it is responsible for identification of faces, okay, and identification of structures by looking at them. So if any lesion occurred there, we may end up with visual agnosia, that a person, when he sees somebody, he cannot identify them, but once they hear their voice, they can identify them. The occipital eye field, actually, it is thought to be located in the secondary visual cortex, and its function as a reflexive conjugate deviation of the eye. That's in contrary to the frontal eye field, which is a voluntarily movement horizontal gaze. This is a reflexive conjugate deviation of the eye. When the eye is looking at a moving object, reflexively the eye will deviate. Now, last but not least, we will talk about the insula. The surface anatomy of the insula is located deep in the sylvian fissure. We have the circular sulcus around it and the central sulcus, which lies in continuity with the central sulcus on the lateral surface of the hemisphere. We have three anterior short gyri and two posterior long gyri. The number may be more or less. The function and lesions to the insula, it's thought to be important in planning or coordination of the articulatory movement necessary for production of speech. That's just a postulation. Now, the last thing I want to talk about is the cerebral dominance. About 96% of population have their left hemisphere is dominant for speech. Okay, so even some of the right-handed person and the left-handed person have their left hemisphere dominance. The right hemisphere actually has a spatial orientation. The music and the art is represented more in it, while the left hemisphere is more pronounced with the language, with the mathematics, and the thinking things. Well, I finished my presentation. If you have any question, please don't hesitate, ask me. I'm waiting for your questions now, and thank you for your listening. These are the references you may look for more details: clinical neuroanatomy, SNELS, and the fundamentals of neurosurgery. And thank you. I'm now waiting for your questions.
Thank you so much, Mustafa, for the presentation. If anyone has any question, you can raise your hands, please. Okay.
Nobody has any question?
Okay. So if nobody has any question, we are moving to the presentation of Ahmed Khalil. Are you ready?
Okay, just before that, I want to mention that these are some of the references I used for my first presentation about the surface anatomy of the cerebrum. If anybody interested in the references, they can look for it.
I see Humam raised hand. You have a question, Humam?
Yes, hello.
Hello.
This is my first lecture, so I was a bit hesitant about my question about Dr. Mustafa presentation. About apraxia, you said is it a coordination of movement problem because the person can't do the tasks very well. Is it a coordination of movement like the spinocerebellar tract because you need to know where is your muscles or hands is located before you move it? Is it like the spinocerebellum tract lesion where it's about the proprioception before you move the muscle?
No, actually, it's not about that. It's about the stored programs for that specific task. So I gave you an example. If you want to drink a cup of water, you are thinking of, first of all, holding the cup, then approaching it to your mouth, then have some sips, then remove it back. This program is stored in the premotor cortex. So it's not about actual lesion in the proprioception fibers, the sensory or the motor fibers. They are all intact. Okay, so the problem in how to program that task, how to make it stepwise. Okay.
Yes, thank you very much.
You're welcome.
4 comments in general. Mustafa presentation, more than perfect. He's like a master just giving his presentation. My comment for him is that we have a deal that either it's interactive or it's just short presentation, then followed by interaction. So I think maybe he has not the time for this presentation, but next time I would expect either 15-minute presentation, solid presentation without interaction, followed by Q&A. Already you should prepare the Q&A part because most of the students are new and they don't have the full courage to discuss every detail. That's number 1. Number 2, obviously, when you have more than 40 minutes doing the presentation, you will lose the pace at the end. So it's like there is a lot of stops and we didn't know what's the next slide and how it's connected by the previous slide. And with the time, you will make more coherence between the topics, like better than doing, oh, okay, this is Broca's area, and after 10 slides, we go just close to the Broca's area, to the gustatory, and after 10 slides, we go just close to the whatever area. Better to have connections, and this is require professional presenter like you, like Mustafa, and with the time, I mean, experience, practice. He should practice his slides because I think he has not the knowledge. Everybody know that the slides are very interesting, and for those who already prepare slides for today, like Ahmed and Abdullah, they know what's the time that actually Mustafa spent with each slide during preparation, so they can appreciate better how difficult to put a nice slide, then 10 slide, then 100 slide. So that's for Mustafa. So as a reference for the future, this is a real book. I think better than using the lateral occipital sulcus, which is not a real sulcus, dividing the occipital lobe into 3 gyri that's not there and not applicable for neurosurgery. Better to use a real reference. Okay, that's my idea. Handbook, Greenberg handbook is definitely the best reference for us. Humans, as Mustafa showed you, it's the real or the official textbook for neurosurgery all over the world. These are the main Bibles, we call them in neurosurgery, the Greenberg handbook and the humans textbook. Everybody like study the Greenberg from skin to skin, from cover to the end, and humans is for when you need to understand some topic. These are the main references. Others are optional. Snail anatomy, as Mustafa showed you, that as a beginner, yeah, snail, very interesting, very efficient. And later, at a later stage, like Mustafa stage, you can see that Roton is the best reference for anatomy. Other books are under negotiation, like for this fundamental book that Mustafa showed us. That's interesting, but I feel that this book, the worst one describing the function. Why? Because it's, if you find the affiliation of authors and what are the department of authors, then you can understand who should describe the function. Is it a neurology or neurosurgeon? It's medicine. Who's the best describe the function of the cortex? So just an ideas about what are the references, because now you are having a step forward, Mustafa, with Ahmed and Abdullah, and let's have a next level comments. That's my comment in total. If you have any comment or a question to anybody, I'm here. This is easy comment, but I think the effort behind, I think you can feel it more, or you can describe how hard to build these slides and even time management.
Yes, exactly, Ami. Well, it's my hobby to do presentations. Indeed, I'm interested in education. So I take the presentation as a challenge to myself, even if I am compressed with the study at medical school. I like the difficult topics. For example, the functional area of the cerebral cortex is a tough topic with a variety of resources and different aspects of knowledge inside each reference. So I tried to look at them all and gather all the most high yield information I thought about and put it all together. I was thinking about doing it in 2 separate presentations, but then I had to do it one presentation.
The presentation to be interesting, like if Mustafa is not my best friend, actually, I don't care. But for me, next time, I would prefer to see Mustafa doing a 10-minute presentation, okay? Doing very simple topic, very nice idea, different idea, too engaging, and spending 30 minutes just discussing different question with a funny intention. That will be the best, okay? Better than this, my retired grandfather giving me lecture about anatomy, and okay, I drink and eat a lot, and thank you for your time. If you have a comment, Mustafa, yes?
No, Ami.
Otherwise, let's go to
Okay.
Ahmed.
Thank you, Ami.
Thank you for being tough to me. Okay.